session. Usually there's fewer people than this, so we sort of have a kind of roundtable discussion and maybe answer some questions about transplant.
Maybe you want to
if maybe I just start speaking, and then if people have questions, they can raise their hands or ask questions or have comments. Is there anyone here that's had a transplant? So what, one person? Okay. Okay. So it'd be quite a long time ago. Okay. And is anyone here being considered for a transplant at the moment? So again, one or two. Okay. And so you'll have heard all the fantastic talks earlier about how good tyrosine kinase inhibitors are and how good the drug treatments are. But for a small number of patients, sometimes transplant is the only option, and that can be because the CML is resistant to treatment and people have gone through multiple tyrosine kinase inhibitors, or sometimes it can be because the bone marrow just doesn't work properly, and every time change drug, try a new drug, the blood counts drop. BCR-ABL never goes down despite the blood counts dropping all the time, and at that point we need to give people a sort of new healthy bone marrow and a new healthy immune system. So the way that we do transplants has moved on in the last 20 years or so. We're able to offer different types of transplants now. We can offer different donor options. So when transplants were first done, people needed to have a matched brother or sister donor in order for a transplant to be done. But now we can transplant from brothers and sisters, unrelated donors. We can do cord blood transplants, and we can also do what are called haploidentical transplants, where the donor may be a half-matched brother or sister, a parent or a child. So for almost everyone now, we can find some sort of a donor. We're also much better at what's called the conditioning for the transplant. So that's the treatment that your body needs to have, your bone marrow needs to have in order for you to accept the stem cells. And this is, in the past, was a very aggressive form of chemotherapy combined with radiotherapy. But nowadays, for the majority of patients, this is a combination of more gentle chemotherapy, often with some immunotherapy. And then this means that patients are in hospital for less time, their blood counts recover more quickly, and they're able to return to activities of normal living a bit more quickly. In terms of which patients have transplants for CML, the majority of patients having transplants for CML are patients with blast phase disease. And any patient that either presents with blast phase or progresses to blast phase, if they're fit enough and they have a suitable donor, they should really be having a transplant. For those patients with accelerated phase CML, so that in-between condition, if those patients don't have an optimal response, so if they're not achieving 10% by 3 months, if they're not in complete cytogenetic response by a year, they should be proceeding to transplant because there's a risk that they're going to develop resistance more quickly. But for patients with chronic phase CML, the decision of when to transplant or not is much more difficult, because now that ponatinib's come along, there's some interesting evidence from the French group that actually for patients with chronic phase CML, if you're able to tolerate ponatinib, then that has a better outcome than transplant because of the risks of transplant. So we're in quite an interesting situation, and it's actually very difficult for patients with chronic phase CML to decide when to transplant or not. So I don't know, Dragana, if you've got any thoughts on that as coming from another transplant centre.
So only to say that it has moved from first-line therapy before the TKIs to now fourth-line therapy after ponatinib. But not everyone can have ponatinib because of the risks that we spoke about with higher doses long term. And sometimes patients don't respond to ponatinib very well, so you can only give a very short period of time on this drug until you move on to stem cell transplant. But the outcome with a young patient, good donor, is the same as with upfront imatinib. So you have to position it very carefully, because our outcome in the later phases, as Mhairi said, is really not as successful. Now that we have the drug asciminib, we might be able to rethink where we position stem cell transplant, because we have another agent that seems to be better tolerated without the vascular side effects. Are there any questions about?
Hi. Is there a point where transplant becomes an option given the age of the patient? My son was diagnosed with CML at age 15. So, we've heard some wonderful stories of people who've had 20 plus years.
Mm-hmm.
But if a normal life expectancy, that could be 50, 60.
So I think we are getting more information about. Is your son on one of the tyrosine kinase inhibitors, or did he have a transplant?
He's on dasatinib, which was his second drug. He started on imatinib, but had the blood response, but still had 100% Philadelphia chromosome in his bone marrow. So they changed to dasatinib, and he's now major molecular response.
Oh, that's good. So initially there wasn't a lot of information about the tyrosine kinase inhibitors in children. So until really quite recently, the majority of children, even having a response, went on to have a transplant. But we now know that probably these drugs are as safe in children as they are in adults in terms of the response to their CML. There have been some issues in pre-pubertal children, so children maybe under the age of 12, where there have been issues around stunted growth and other problems just because of some of the side effects of imatinib in particular. In terms of dasatinib and side effects, the main side effect we worry about is the pleural effusion, and that's very much age-related, so it's vanishingly rare in people under about the age of 30. In terms of where your son would go from here, we would recommend he stay on dasatinib at the moment. They are starting to do some stopping studies in children, but at the moment your son wouldn't be eligible because he'd failed the first line imatinib. But as we get more information going down the lines and over the years, then hopefully at some point in the future, if he has a better response and has a sustained really good response, he might be able to stop or dose reduce in the future.
So yeah, he's 11 years in now, so he's that has been discussed with him about about stopping or reducing his dose.
The other thing is, as I said, there's new agents coming along all the time. There's asciminib, but it might be as we get more information about the new agents, we might be able to stop more people. They might be more potent with less side effects, but at the moment we just don't know.
We had a paediatric CML session last year. I don't know if that's still available online, but the very interesting thing from our paediatric colleague is that children just don't get pleural effusions at all. So we have to think what's really behind that immune profile for children and then later adults. But it's a very good response, major molecular response. So hopefully that's maintained and the dose can be adjusted as time goes on. Back to transplant. Are there any questions about what happens after the transplant? It's quite an undertaking, so obviously we're delighted when we had all these tablet therapies. So we usually anticipate that the time as an inpatient after the chemotherapy and then the cell delivery will be around 6 weeks on average, and then quite a few hospital visits afterwards. So that does impact on work, and the complications after transplant need to be carefully adjusted. But some patients bounce back very quickly and then start working again 3 months later, and then some patients obviously have more complications. It's quite an involved procedure, requires a lot of monitoring and attending hospital. But again, patients who had transplants before TKI therapy are very pleased that they're not on TKIs and that they don't have the side effects that some of our other patients do. So it depends the outcome and how you respond to the individual treatment. Sorry, can I just come through?
I was just wondering whether there's been any real improvement in recent years in ability to deal with graft versus host disease and also with particularly given the greater risk of that in older people.
So there's a number of ways that the therapy has been improved. So when transplants are given to older people, it's the reduced intensity transplants, and the T cells, which are the blood cells that have the tendency to cause the graft versus host disease, are often taken out of the transplant, and the patient has their T cells removed before the transplant. And then if we need to, we put the T cells back later. If we've still got evidence that there's still some BCR-ABL there, we can reinfuse the T cells after the transplant a few months down the line to try and sort of boost the immune system a bit more. But in addition to these manipulations of the transplant, the drugs that we use, the anti-rejection drugs and the drugs to reduce graft versus host disease, have also improved, and there's a much wider range of drugs available. There are also other procedures, particularly for things like skin graft versus host disease. We can do phototherapy. So there's new treatments coming along for graft versus host disease for those patients that have severe graft versus host disease. Often, if patients have a small amount of graft versus host disease, that's good because it means that the immune surveillance is working well and it will detect any existing leukemia cells and get rid of them. So as transplanters, we like a little bit of graft versus host disease that's maybe present for a short time and then goes away. We don't want patients with extensive and chronic graft versus host disease because that has a really detrimental effect on quality of life.
What's interesting, apart from the manipulation to prevent graft versus host disease, are the new drugs for graft versus host disease. So imatinib is a drug for graft versus host disease because one of its off-target effects. So it's particularly good for skin and eye graft versus host disease. And there's some other drugs which are, that pathway is being developed with some new trials at the moment to try and spare steroids, which can cause complications with infection and bone thinning as time goes on. So it's definitely more and more development in the treatment aspect as well as prevention aspect, regardless of age, and the matching is also much more sophisticated than it was.
Are transplants more effective using a family donor than a stranger donor?
So that's a really good question. So it depends on the age of your donor, the sex of your donor, how well matched your family donor is. So the ideal donor would be a fully matched family donor because you're less likely to get graft versus host disease. Failing having a fully matched sibling donor, then the next best option is a matched unrelated donor. And if we're looking at matched unrelated donors, the ideal donor is a young male donor because you get a bigger stem cell dose and they've been exposed to less antigens than women have. And because they're younger, their stem cells are fitter. After that, then it's a sort of discussion between cord blood transplant and a haploidentical family donor. But for somebody with chronic phase CML, if they had a family donor, that would be the optimal donor, not just in terms of the match, but also you can access that donor quite quickly. They're nearby. If you need to go back for donor lymphocytes, it's easier. But for an unrelated donor, you can do everything the same. And sometimes for more aggressive CML, there's no difference in the outcomes between a matched family donor and a matched unrelated donor.
Is there a risk of CML coming back after transplant?
Yes. So regardless of the type of transplant you have, there is a risk that the CML will come back. Now, if you have a transplant for blast phase CML, in about half the patients at least, the CML will come back. So for blast phase patients, we would look to try and give a tyrosine kinase inhibitor again after the transplant to try and maintain the response. We might also look at giving donor lymphocyte infusions, even if we don't necessarily see the BCR-ABL in the blood still after the transplant. For patients with chronic phase CML, for younger patients, if they've had a full transplant with the chemotherapy and radiotherapy, the chances of the leukemia coming back are quite small, maybe of the order of about 10%, 15%. But for somebody that's had a reduced intensity transplant, maybe about a third of patients will relapse from that. But that is salvageable in the majority of patients with donor lymphocyte infusion, which is why after a transplant it's really important that you're followed up regularly and your BCR-ABL is checked regularly, so that if we start to see a trace of the BCR-ABL in the blood, we can restart a tyrosine kinase inhibitor and we can get donor lymphocyte infusions organised. We can also look at adjusting the drugs that you're on to prevent graft versus host disease and prevent rejection. So that's why if somebody has a transplant, they're seen very regularly at the clinic to look for signs that the CML might be coming back or they might be rejecting.
Is there a risk of bone marrow failure after you've had a transplant?
So that's just the rejection risk, and it's unusual with CML. It's more common with some other conditions, but it's about 1 to 2% of patients may have either bone marrow rejection or bone marrow failure. But if you've got a fully matched donor, that's unlikely. It's more likely to happen if you've got a mismatched donor. If you have a cord blood transplant, it takes much longer for the blood cells to recover as well, but they will generally recover.
Up until about 3 or 4 weeks ago, I was looking as though I might have to have a transplant. And the information that I was given was that the younger and fitter you are, the more likely it is to be successful. Now, I'm lucky that I don't have to have it anymore, but it's a possibility way into the future that it might still happen. So what age is really considered a young person to have a transplant, sort of going forward, if it was in 10 years, say?
So we will transplant, we try to look at what's called biological age as opposed to chronological age, because you can have somebody at the age of 50 who's never smoked, who exercises every day, who's very, very fit, or you can have somebody from my part of the world that drinks and smokes and has a really bad diet, and at the age of 50 is more like an 80-year-old from somewhere else. So we try to look more at the biological age and make a decision. But if somebody's reasonably fit, even into their late 60s, then they're probably going to be fit enough for a transplant, and it would be our job to decide how intensive that transplant should be, whether it should be a full intensity transplant with the strong chemotherapy and radiotherapy, or a reduced intensity transplant where there's less chemotherapy and we maybe have to look to restarting a TKI afterwards with donor lymphocyte infusions. But I would have said people who are fit up until their late 50s, early 60s are going to be fine to have a transplant.
So I think, 50 is our cutoff for reduced intensity or the total body irradiation, which is the full intensity with chemotherapy. But I think our oldest transplant patient is 71, 72. Mm-hmm. And I know in Italy there are patients who have been transplanted who are older than that. And the world is changing, so when you modify the conditioning, the cells, use the immune system, it's again variable, like Mhairi said. But there is no specific age cutoff.
Is the difference between a reduced intensity or full intensity, however you call it, does that make a difference to the outcome?
That's a really difficult question to answer because they tend to be done in different age groups of patients. So younger patients tend to have the more intensive transplants, which still come with a small risk of dying from the toxicity of the procedure of probably around about 5 to 10%. In the reduced intensity transplants, probably the risk of dying from the procedure is about the same, 5 to 10%, but that's in older patients who are maybe a bit less fit. They might have a bit of hypertension, they might have some mild diabetes. So you're starting at different points. I'm not sure if that completely answers your question.
So in general, the outcome's meant to be the same, but you have more complications in the full intensity one, and then more chance of relapse in the reduced intensity one. So the overall outcome in general tends to balance itself out. But it all depends on how many TKIs you've had before, about the choice, because you need to think about what you're going to do afterwards, and according to the phase of the CML. So it is finely positioned, as Mhairi said.
So when for somebody going for a transplant or being considered for a transplant, when they see the transplant team, they have a kind of scoring system for other health problems that you might have, and they will use that to predict how successful the transplant is likely to be. And that's not particularly based on the CML, it's based on other medical conditions you might have or may have had in the past. And then they will use that to advise you on what they think the risks of the procedure are.
Can't think of any more new novel approaches for transplant that we can entice you with.
No.
I think that when we only had imatinib, we did a study when our approach was full intensity transplant to do reduced intensity and then introduce for the first time imatinib just after the cells came back. And the outcome was very good. And at 1 year, patients stopped imatinib, but that was about 10 to 15 years ago now. So it's still evolving, trying to use TKIs. Trying to reduce the toxicity or the side effects of the procedure.
The one thing I thought somebody might have asked about was something called CAR T cell therapy. Have people heard of CAR T cells? Yeah. Perhaps for children with acute lymphoblastic leukemia or patients with lymphoma. So this is an immune-based treatment that is becoming increasingly relevant in both hematological conditions and I suspect in the future in solid cancers as well. It is effective, extremely effective in some patients with resistant acute lymphoblastic leukemia and resistant lymphoma. They found a specific target on those lymphocytes that they can target the CAR T cells to. For conditions such as CML, we don't have such a target that we can identify for the CAR T cells at the moment, but that may be something that's coming down the line in the not too distant future. I don't know, Dragon.
Which will avoid transplant.
Which will avoid transplant, yeah.
Just arising out, this is something I was going to ask in the final session, but I'll ask it now. A few years ago, there was quite a lot of interest in antigenics and immunological approaches to treating CML. I haven't heard anything about it in recent times, and all the discussion today has been about new drugs. Mm-hmm. Is anything happening in that area for CML? Apart from, well, you mentioned CAR T. But
so they have looked in the lab at the PD-1 inhibitors. So this is drugs like ipilimumab and nivolumab that have been effective in solid tumours and some lymphomas, particularly effective in melanoma. But the PD-1 receptors are actually reduced in patients with CML. They come back up when you treat with a TKI to normal levels. They're not overexpressed, and there's no evidence that, for example, a PD-1 inhibitor is of any benefit. There have been some vaccine studies done, particularly in Italy, and Richard Clark, who was here earlier, they did a vaccine study, but they didn't show any benefit over imatinib alone. There's a number of studies combining interferon with TKIs, and they do look like they may be a little bit more effective than the TKIs on their own. And they're using a new form of interferon, which is given once a week, so it has less side effects, and you get less less injection site reactions because it's only once a week. And we're really just waiting to see the final readouts from these studies. But historically in the UK, we've struggled to deliver interferon in clinical trials. Whether that would be different with the pegylated form, I'm not sure, but that's something potentially that could be addressed in the future. There have been some targets identified on the surface of CML stem cells. Some of these targets are also expressed on normal stem cells and on the cells of the blood vessels, so they're not going to be suitable to target. But they are looking at identifying or developing things like CAR T cell therapy towards specific targets on the CML stem cells. And there's a molecule called IL-1RAP, which is expressed on CML stem cells and on some AML stem cells, that they're looking to see if they could develop that for CAR T or other immunologically based therapies.
Is your hydroxychloroquine study?
So that wasn't immune-based, that was targeting a process called autophagy, which is where the cell, in response to stress, and that stress could be giving imatinib to the cell, it starts to eat other parts of the cell to keep the cell alive. And the way hydroxychloroquine, which is a drug used to treat rheumatoid arthritis, works, it inhibits that survival pathway within the cells. But we weren't able to deliver the hydroxychloroquine at sufficiently high doses in order to consistently inhibit that pathway. It would have been too toxic. So we need to develop, and there are more potent autophagy inhibitors in development. So that may be something that we can revisit in the future. But these drugs need to have an extremely good side effect profile to be given with the tyrosine kinase inhibitors.
I think combination study, there's in the MD Anderson in America, there's a combination of upfront dasatinib with targeting a survival pathway of the stem cell. The drug's called venetoclax. It's a BCL2 inhibitor. So the combination of TKI with this to target the stem cell is another combination approach, and we need to wait for those studies to mature before we see what the combination has done.
But these studies are actually incredibly difficult to recruit to, because the majority of patients are actually doing pretty well on their tyrosine kinase inhibitor, and then to add in something else that may have side effects, additional visits to hospital, additional bone marrow tests, is really not very attractive, which is completely understandable. So we've got to a very good place with CML, but getting that final step potentially to cure some people is going to be quite challenging for all those reasons.
Saved by the host. Okay, so we'll wrap up this session and take more questions in general on CML shortly.